Hi, and welcome back to the WHY-O-MYO podcast. This is Janine Steen, your host, hoping to answer your questions about the who, what, where, when, why, and how when it comes to myofunctional therapy. Disclaimer. All content and details, as well as education shared on the podcast, are the opinions of the speaker and for informational purposes only. Please consult with a certified medical professional regarding any questions or concerns, as this podcast should not serve as a diagnosis or replace the information that you have received from a healthcare provider. As I mentioned in my last podcast, I have spent a lot of the last few months attending and presenting at lectures and conferences all over the country. And what was wonderful about the presentation is that it wasn't limited to just speech pathologists and it wasn't limited to just orthodontists, but it included an array of medical, dental, and rehabilitative specialists with a focus on airway. So the one conference that I was lucky enough to present at with my partner in crime and the director of my of their speech language pathologists in the center. We presented at the Breathe and Thrive conference, which last year we were in attendance and we were in absolute awe of some of the professionals that had spoken at that event, such as Dr. Zaghi and Dr. Baxter. Some of these lectures blew my mind, but not only that, to be looking at the doctor who has written some of the most groundbreaking research in the field of myofunctional therapy, in the field of tongue tie, and whose views align completely with mine or ours, Tony and I, and our center's view. It was such a breath of fresh air, and especially going that first year, it had been, I don't think it's ever been, unless I've been in an exclusive myofunctional therapy conference, but no other conference have I ever gone to that related to speech pathology or dentistry or airway that myofunctional therapy was considered a focus and one of the areas that was continuing to be highlighted as a benefit for treating and improving so many different disorders. And aside from that, especially at the Breathe and Thrive conference, there was such a large focus on the frenum, the lingual frenum, addressing the lingual frenum, the negative effects of a short lingual frenum, and that list went on. And it wasn't that long ago that I would make a referral for frenectomy, and I would hear from the parent that would say, nope, the dentist or my pediatrician doesn't think it's necessary. And especially as a myofunctional therapist and wanting nothing more than to see the patient succeed, I knew that if we didn't have more range of motion and more tongue mobility, we would never be able to successfully correct their tongue thrust and all of the symptoms that have developed as a result. So I would, call these doctors or dentists after the parents would come back, and again, very respectfully, because, we do defer to them as the professionals or the medical professionals, but very respectfully, inquiring about why they didn't feel this patient was a tongue thruster, or why they may felt that they were a tongue thruster, but they didn't feel that the frenum was an issue and wasn't negatively interfering. And what the reasoning was, the patient can stick their tongue out, it can touch the vermilion borders of their lips, so therefore they do not need a frenectomy. And it used to frustrate me so much when I would think about it, because it really is dependent on jaw height. So if a dentist, doctor, whomever asks their patient to stick out their tongue and touch their top lip, it varies. So if they can open their mouth, stick out their tongue, and while leaving their mouth completely wide open, they can touch their top lip or the vermilion border of their lip, then absolutely, they do not. They do appear to have full range of motion and do not need a frenectomy, or at least does not appear to need one. But if you tell a patient to open their mouth, stick out their tongue, and touch their tongue to the vermilion border of their lip, and in order to do so, they have to close their mouth or approximate their mouth closed a little more, or jut their jaw forward, or stabilize their tongue with their teeth, well then no, those patients are not able to adequately touch the vermilion border of their lips because they're not dissociating their tongue and jaw. So if the jaw height varies or changes because of that question of can you touch your tongue to your top lip, then you have to really look and see how much of a difference. If it's a minute difference, then maybe the doctor or we are on the fence about a frenectomy and we'll try some exercises first. But for the most part, if that patient has to move their jaw at all in order to move their tongue, then that patient most likely needs a tongue tie release or a frenectomy. And many years of doing this, so after many years of doing this, I used to, not only did I have that conversation with many different medical and professionals and dental professionals, and often I would have to concede and say, okay, we'll attempt to work with it as it is. We will attempt to improve their dissociation skills. But if we don't see much improvement, then we're going to, just send them back to you. And we would. Our therapists would work diligently trying to improve their lingual range of motion and their tongue-jaw dissociation. And often we were unsuccessful because we knew that it was the tie or the tethered oral tissue that was really what was interfering with those dissociation skills. And without being able to dissociate their tongue from their jaw, they'll never be able to progress through a myofunctional therapy program, never mind progress naturally through the developmental stages of feeding and swallowing. So that has definitely changed. I do feel that medical and dental professionals are more cognizant of what to look for. They understand that it's not just about mobility, it's about mobility independent of any other structures. Or those professionals that used to say, no, I don't think they need it, they'll also say instead, I'm not sure, you should get a second opinion. And yes, for a parent, I can imagine, and a patient, that's frustrating. But I appreciate even more their honesty in terms of making that recommendation, because if your child or if you need it, it can make a huge difference in the amount of progress, the rate of progress, and overall success. So you really want to have someone that really knows what they're looking at. I definitely see a change in people being more cognizant of tethered oral tissue and making the recommendations sooner than later for a consultation for a frenectomy. But this is another area we have a long way to go. There definitely needs to be a Frenum protocol in place. And just like when you're an infant and every time you go to the doctor, they give you a list of all the things your child should be doing, what what stages are coming up. When they ask you questions at the office, are they babbling? Are they crying? Are they all walking, sitting up on their own, rolling over? There really should be a specific period of time when the frenum, all the tethered oral tissues are assessed, whether it be the labial, lingual, and buccal ties via the pediatrician. They should also talk about their chewing patterns, their swallowing patterns, their dietary repertoire, and how it relates to their weight gain or overall growth and development. And then the last thing is some questions, again, whether it be during that first year of life and then at every physical, asking some questions about sleep apnea and sleep disturbed breathing, discussing the symptoms associated with pediatric sleep apnea, assessing the tonsils and adenoids a little more, tonsil and adenoid pad a little more closely, and at that physical, just taking a baseline of the airway and the patient's overall lingual labial mobility, as well as their dietary repertoire. I think that if we can make this a regular part of physicals and growth during those first few years, I think that, again, we'll be able to intervene sooner and hopefully break some of these non-nutritive sucking habits or non-nutritive noxious habits sooner than later, and therefore give them less of an effect on the oral cavity, as well as create limited symptoms secondary to their tongue thrust. I do think that this, again, still has a long way to go, and hopefully there will be a protocol in place so that every physical at the pediatrician, every cleaning at the dentist, every start at the orthodontist or beginning of their treatment, middle, end, all of them will include assessments regarding the frenum and assessments regarding the airway, so that hopefully we can intervene early and maximize some of these patients' overall success.
I hope I was able to give you some insight and answer some of your questions regarding myofunctional therapy. Please stay tuned and listen to our Myo Minute, and tune in to our Talk the Talk interviews with the many different medical, dental, and rehab professionals as they elaborate or answer your questions and address your concerns directly, especially when it's related to speech-language pathology and myofunctional therapy.